Hi, it's Dr. Kevin Miller. Welcome to our Doc Talk COVID edition. I assume most of you or all of you should be at home sheltering in place as recommended by our governmental and state/county agencies. We're all dealing with it in our own special way. As you can see, I was left alone with a pair of clippers, and as a military guy, this is the haircut that I gave myself. So this is my COVID 2020 haircut, and this is sort of the most helpful way for me to get through all of this. I'm going to try to see if we can share my screen. There we go. There's my slides. So what we'll do is I'm going to just kind of introduce myself to everyone so that we can see things and go from there. I can see our other half. Her name's Kelly, and she's very helpful with kind of going through my slides. So anyway, again, I am Dr. Miller, Kevin Miller. I'm the podiatrist here at NorthBay Orthopedics. I have our offices in Vacaville and Fairfield. I'm mostly in Fairfield. I've been practicing for 11 years. Bear with me, guys, as we work through the technology part of all of this. So I'm going to share my screen with everyone. Okay, my application, no. Application window. No, that's not what I want to do. Cancel. There we go. How come it won't let me? I apologize for the technological difficulties here, everyone, but bear with me. We'll get going. Anyway, Kelly, if you're on the other end, there you go. Can you just help me go through this? Anyway, here's some stuff about me. I am the only podiatrist at NorthBay, which is great for me, and I've been very happy with the medical group now for about the last 5 years. Things have been very good for me. I'm very busy. I have lots of patients, obviously, from Solano County, Yolo County, Napa County, Contra Costa County. I'm very happy. I kind of do a lot of different things. I'm a sports medicine guy. I volunteer at a local high school in Vallejo, St. Pat St. Vincent's, where my children that you see on our screen will end up going. I'm also a limb salvage guy, so I deal with a lot of diabetic patients who require advanced treatment, both surgically and with kind of other services involved with vascular surgery and orthopedics, sometimes plastic surgery, depending on what it is. I am the only person in this county that I know of that's doing joint replacement of the ankle. So we have a really kind of robust joint replacement program here. And we're all very happy to be involved with that. I am involved in academic research. I have a few cookies in the oven with that right now. We have a couple research programs and projects that are sort of on hold during COVID. But once they open things up for us, we should be able to kind of get back in to the swing of things, both in operating room and in the clinic situation. I'm a proud military veteran. I was a Navy hospital corpsman stationed with Marines. I have an FMF designator as a corpsman. You know, I spent my time there kind of taking care of Marines, and that's where I got the start in medicine. And I'm a family guy. I'm a big believer in family, and my life is kind of revolves around the two little munchkins that you see on the picture on the screen. They are at home right now, obviously, with my wife, who now is a teacher, apparently, as are all mothers, fathers, grandmas, grandpas who are at home with the kids these days. But anyway, so that's just a little bit about me. So now let's get into the meat of our program. There's just a picture of me and the boys. This is actually last summer down in Monterey somewhere. My wife was able to snap a pretty good picture. That's me with hair and with some facial hair. The boys look the same. So All right, so the objectives of today's talk, we're going to talk about some foot and ankle problems, some very common issues that we see and deal with. I see lots of this stuff in my practice. Even now during COVID, I'm still seeing these kind of things that are problematic for people. Heel pain, plantar fasciitis, we'll talk about. Bunions, we'll talk about. Fungal and ingrown toenails, of course, is always a big issue. And then something that I deal with a lot because of just the population in our county is foot and ankle arthritis. We'll also talk about treatment, some common treatment options for people, both surgical and non-surgical, which I think is always good to hear both sides of the sword for that one. At the end, what we can do is we can have some questions. I guess it'll just have to be email or typed in questions, and Kelly and I will sort through things for you. Okay, Kelly, go to the next slide. All right, so the foot and the ankle, pretty complex part of your anatomy. Everything kind of plays off of each other. There's lots of bones, there's lots of joints, lots of ligaments. Figure ligament attaches bone to bone, and tendon attaches muscle to bone. And so in the foot and the ankle, there are 4 different compartments of muscle that all have their own tendons, and there's many ligaments that can be injured. The joints themselves can also be problematic individually. So it's sort of a big push when it comes to things. For me to make the correct diagnosis, I have to really sort of be able to hone in on what the problem is. Next slide. So one thing that I am a big proponent of is proper shoe gear, proper fit of shoes. I think that in itself prophylactically can prevent and sort of slow down a lot of foot and ankle problems. The best time to do your foot fitting, if you're going to get a new pair of shoes, is later in the afternoon. Never go in the morning. Not much swelling in the morning. Go later in the afternoon. That's really more of a true foot size for you, because you don't want to get the wrong size shoe. You always want there to be a little space at the end. Fit it to your larger foot. Believe it or not, we are asymmetric. Whoever you believe created you didn't create you completely symmetric. We're not robots. So, and just make sure you get the proper last. What the last of the shoe is, it's the shape of the bottom of the shoe. Some people have more of a C-shaped foot. Some people have more of a straight foot. Some people have sort of more of a flat foot, obviously. Always try to get the right style of shoe. If you're a runner, you want to get a running shoe. If you're a mountain biker or a mountain climber, you want to get a shoe that's good for that sort of terrain. Look for good. I say good shoes. Good shoes can be dependent on your preference, but you want to get a shoe that's constructed well, and there are some ways to look at that. Obviously, the more expensive a shoe, a lot of times you're getting a better shoe. The cheaper the shoe, the more chance you do have of it wearing out. With or without orthotics, that's really up to you, depending on your foot or your foot problem that you have. Orthotics are great, but they're not magic, and they only work when you're wearing them. I am a big proponent of that as well, but I also think that sometimes they're not necessary, and I will be glad to make those recommendations to you if you need me to. Anyway, next slide, please. All right, so plantar fasciitis. This is very commonly seen in my practice. It's an inflammation on the band of the bottom of the foot. It's sort of like it's a fascia. So fascia holds muscle in position. It can get irritated, it can get stretched, it can get torn, it can get scarred down for multiple different reasons. It leads to inflammation and pain. People come in with, I have a bone spur in my heel. My primary care doctor told me I have a bone spur. Well, the bone spur is usually secondary to the pull of that fascia on the plantar aspect of your foot and your heel where it originates from. And so this can be for multiple different things. There's variables that play into it. There's never one variable. Usually it's more than one thing. Usually, people have pain in the morning when they get out of bed. They have pain after prolonged rest, and then they get up to stand. It feels, like there's somebody stabbing them in the foot. Sometimes it does get better after periods of walking, but it's really kind of individualized for that person. So Next slide. It can be aggravated by poor shoes. You know, if you're wearing real thin flip-flops all the time and you have this, it's probably not going to help you. Rest can only provide temporary relief. And as you walk, you know, throughout the day, and this happens in a lot of people, they get up and the worst pain is in the morning. It may give you sort of a false sense of relief for that day. And you're like, oh, I feel great. And then the next time you sit down and get up again, you're going to have the same sort of pain and issues. And that's where I come in with some treatment options. So next slide. Early treatment options. I mean, I kind of have a sort of a set way to treat this. I don't try to treat everyone the same because people are individualized and things, but we do use physical therapy, shoe recommendations, exercise recommendations. We do some strapping and taping, orthotics, and then kind of down the line after some of that stuff doesn't work, physical therapy actually gets employed pretty early. We can do anti-inflammatory or steroid injections and sort of use anti-inflammatory medicine as needed. So surgery is like the last option for this most of the time, and that's after kind of failing all of these treatment options that we've gone through. That's usually 6 to 8 months down the line. We do an endoscopic procedure. We go in and we cut the tight fascia, the inflamed, irritated fascia. And that's an outpatient surgery. It takes about 6 or 7 minutes to do the whole thing. It's quick and easy. Recovery from that is very fast. There's 2 little incisions. You can walk on it right away. But again, it's about 5% of people don't get better from fasciitis and go on to surgery. And then about 1% of that 5% don't get better with anything that we do. And so those are the sort of the caveats to plantar fasciitis. Like there are only so many treatment options that we have, and there are other things out there that can be explored. And I don't ever kind of use those as the only option, but I try to individualize and taper my treatment for each patient. So, what can we do to prevent fasciitis? Well, there are some simple things that we can do. Again, wearing well-fitted shoes that have some, shock absorbency to them. When we say rigid shank, if you look on the presentation, that just means you can't bend the shoe in half. Wear the proper shoes. If you're going to go for a run, you shouldn't have on flip-flops. Obviously, that's pretty straightforward, but there are certain types of shoes that you can buy that are more specific for what you're using. Don't wear old shoes. If you have to, you have to. But if your shoes look worn and the bottom of the sole looks worn, it's probably not functioning the way it should be. And then, of course, warming up is always a good thing. This prevents extra stretch and pull and can prevent these plantar fascial issues from occurring. And then listen to your body. That's my biggest thing with patients is be sensible about what you can do, as well as what you want to do. Pace yourself. There are lots of different things that you can do to stretch and get your foot warmed up before any activity, really. And there's, as we age, we should really try to get clearance for some of these things. If you think you're going to start a new regimen of exercise, whether it's just a jog or a walk or a bike ride, or you're going to train for a triathlon, let your doctor know. If they have any qualms with that, then you guys can work that out on your own. But I think it's always reasonable to do that. Here are some basic stretches. We do use TheraBand a lot. So TheraBand is like a stretchy rubber band. You can see the lady is stretching her foot, like flexion extension of the ankle that stretches out the calf muscles and the Achilles tendon. There are some stability exercises you can do going up on your toes in the bottom there. That's kind of like my biggest test for my patients for a lot of things. Even post-operatively, I have them come in, and if they can go up on their toes, that just tells me that there's enough strength and mobility and flexibility for them to be able to progress. I'm a big believer in therapy, and these are the things that our therapists will do for you. So, bunion surgeries and bunions in general. what is a bunion? It's basically an enlargement of the big toe joint that's caused by multiple different reasons. It's caused by arthritis. It can be caused by metabolic problems. It can be caused by trauma. It can cause pain and deformity for sure. And so those of you that have bunions or have had bunions or know somebody that had bunions, it can be problematic. And we don't just get them on our big toe. We can get them on our fifth toe as well. I see some questions popping up about neuropathy. I will gladly address those questions towards the end. I promise you, I have plenty of options for you. So back to bunions for now. We can go to the next slide, Kelly. I call them the gift that keep on giving. Okay, so why did you get bunions? Bunions are brought about, sort of a chronic issue. Years and years, or sometimes short-term abnormal motion and pressure at the big toe joint. We say the MTP, which is metatarsal phalangeal joint. There is a genetic component to a bunion, and it sometimes can get passed down through the family. I always ask a patient, like, did your grandma have this, or did your mom have this, or did your dad have this? And the answer is usually yes, somewhere in there. There's lots of different reasons to have a bunion. It can be from an injury, it can be from a neuromuscular disorder, or a congenital deformity of the foot or ankle sometimes can lead to these things. People that suffer from you're okay, Kelly, go ahead. Bunion symptoms: you get a firm bony bump over your big toe joint, and you get some deformity as well, meaning the big toe starts to point towards the outside of the foot. Redness and pain can also be part of it. You can get some skin issues there from the rubbing in your shoes, where you get a little corn or callus there. And then, the limitation of motion at the joint is also a problem that we see, and we call that hallux, because the hallux is your big toe. You get limited motion at your big toe joint, and that can be problematic. So treatment. Well, I mean, I'm a surgeon, so I have plenty of good treatment options for you, both surgically and conservative. And I think, again, this is really individualized on the patient. Sometimes I get patients that come in and they're absolutely here for surgery. They don't want to hear about it, orthotics, or they don't want to hear about other things. Other times people come in early on and we're able to kind of control things a little bit. Physical therapy is very helpful for this with big toe joint motion. Orthotics are used, and orthotics, it's a custom molded device that I do recommend most of the time for people that have bad bunions, to kind of hold and hold the foot into position that will give it better functional motion at the big toe joint. Anti-inflammatory medications are good, although right now with COVID, we're not recommending anybody take any anti-inflammatories. And then modifying your activities is a good way to do it too. If something hurts, try not to do that for a while until we can get things under control. When should you consider surgery? Well, this is just a general when to consider surgery page. I mean, I think when everyday tasks are painful, if you can't sleep, if none of the conservative stuff that we've tried has helped, and things are just sort of not improving, deformities increasing, you can't tolerate normal activity or life, and pain meds, then it's time to consider surgery. And we have lots of surgical options for bunions to talk about. Next slide, please. Here's a picture of my boys in Benicia. So go back to that one, Kelly. I'll give it a second. This is downtown Benicia by the water. So I live in Benicia, and this is something that the Benicia, the kind of town of Benicia, put in this statue and these blocks that you see in the ground there, and you were able to buy a block for a family member. So my dad passed away from Parkinson's last year, so I bought a block and put his name on it in there, and the boys and I go down and visit him because he's obviously not buried in Benicia, but. So I thought that's a nice picture to include. So bunion treatment, there's probably 160 different procedures to treat a bunion as far as surgical procedures. And it really just involves cutting the bone, moving it over, using screws and plates, depending on what you want. We basically change the structural position of the foot, and reduce the bunion. And that's the main goal of bunion surgery, as well as function. You know, you can reduce it and it'll be locked up, and that's not going to help. You have to try to reduce the deformity, as well as correct and increase the function. So what do you do after surgery? That's really dependent on the procedure. Some people can walk right away. Other people have to wait 6 to 8 weeks, depending on their bone healing. You know, rehab for everyone, depending on what we do have a really good rehab system here at NorthBay, and we're able to get people into our physical therapist pretty quick. And the goal is to get you back to activity, you know, where you were preoperatively. So, and again, really that's dependent on the procedure and the patient. Everybody's different. So again, what can you do to prevent a bunion? You're going to wear comfortable shoes. You know, the avoid high-heeled shoes thing is up to you. I don't know that that's going to completely cause your bunion, but you know, it's obviously not helping. It's putting more pressure on your big toe joint. And a lot of the ladies that I've talked to that have come in with bunions, that are, you know, that have worn high heels their whole life, do relate that to their bunion pain. And if you do, come see me. I'm here in Fairfield and Vacaville, and I'd be happy to help you and give you options for treatment. Fungal toenails. So fungal toenails are a problem, obviously. We call it onychomycosis. That's a big word. And you see the picture of the little toenail guy there. That's from the Lamisil commercial from a couple years back. It's a fungal infection that gets underneath of the skin in the nail, and it actually infiltrates the nail, causing thickening and yellowing of the nail. There are certain people that are more prone, certain people that have with disease processes more prone to this condition. Well, how do you know if you have it? You'll know. If your nails don't look like a normal nail, if they look yellow and thick and there's some flaky tissue, and sometimes they have a smell to them. And for me to know, I mean, I see enough toenail fungus on a daily basis to know what it is. But a lot of times, if I'm concerned that it might not be a fungus, I'll take a chunk of it and send it to the lab, and the pathologist will confirm it for me. They're able to stain the cells. If you look in the bottom right picture, that kind of purplish cells, what look stain is what fungus looks like. It's stained with a dye, and we're able to see the hyphae, which are the little spores of the fungi. And if you do have a positive fungus, we have some treatment options for you. There's lots of treatment options, lots and lots and lots, and there's topical versus oral. The way I look at it, there's surgical treatment, which means removing the nail, and then the laser treatment. I'm not a big fan of the laser. I'll tell you why. The outcomes are not that great, and it's very expensive. Topical medication we use is about 35% effective to treat it. And the oral medication, which is a medicine called Lamisil that you take for 3 months, is 85% effective to treat it. So, it's up to you as a patient which way you want to go. And if your health problem or if your health condition allows it, I always do sort of recommend the oral medicine because it does work better. There are lots and lots of sort of home remedies. People use Listerine, people use, you can go to the next slide, Kelly. Go back. People use Listerine, people use, tea tree oil, people use Vicks Vapor Rub. Those are probably okay. I just wouldn't use, I've had people tell me they've used full strength bleach. I don't ever recommend that. That's going to cause a burn to your toe, and then there's a problem there. So how do you prevent fungal nails? Well, sometimes it's impossible to prevent it, but the best way to prevent it is clean and dry your feet. If you're going to go into a public shower, put on some regular flip-flops, shower shoes, and then, trim your toenails so that they conform with the shape of your toe. Everybody wants to try to trim them straight across, and when you do that, you end up getting these sharp corners in there. It can cause ingrown toenails. Wear the proper shoe, and wear a shoe that breathes a little bit. If shoes don't breathe, it's going to create this sort of petri dish of a rainforest in your shoe, and fungus loves a warm, wet place. Okay, so if you have the choice to wear a synthetic fiber sock, that's always good too. That'll pull the fluid and kind of the moisture away from your foot. And then if you're going to cut your nails and somebody else is going to use them in your household, just disinfect them. An alcohol wipe is good, or any sort of disinfectant will work. Ingrown toenails. So, I do treat a lot of ingrown toenails, and it can be caused, basically what it is, it's the nail starts to grow into the skin. There's multiple different reasons that can happen. It's an irritated, red, swollen toe. It can be caused by you improperly trimming your nails. Again, like I said, sometimes it's heredity. Sometimes it's from shoe pressure. It causes like a TP effect in the toe, and it creates this crowding of your toes, and they squish together. And then also sometimes from repeated trauma to the nail. Like as a runner, I'm a runner, and I have some of my toenails have completely fallen off like multiple times. Luckily, I've never had ingrowns, but I've had runners with ingrown toenails. And this can be from, again, it can just be from normal activity sometimes too. So. Treatment, there are sometimes if it's not bad, we can just soak it and it'll get better. You take a Q-tip and you kind of push the skin edges away from where it's irritated. That's an easy way to do it. Some people, like our diabetic patients, our peripheral vascular disease patients, when they have an ingrown toenail, it can be dangerous because it can become an infection and it can become an amputation, which if you look on the picture, you can see the example of that. Avoid sort of the over-the-counter do-it-yourself treatments. We're here to help. We have multiple different, I have PAs that work with me, and they're great too. They've been trained to treat these things. Don't wait and let it become something that's kind of gone past the point of no return. So removing the nail, like say we just do decide to remove it, there's two ways to do it. We can remove it permanently, or we can remove it so it'll grow back, and that's really just dependent on the person. We numb up the toe, we use some instruments, and I basically cut out the portion of the nail, and actually goes back behind where you see your skin. There's about 3 to 5 millimeters, depending on the person, of skin there that overlaps the nail. We remove the whole thing, that whole portion, or we can remove the whole nail. It just depends on what your choice or preference is. Recurrence from this is about 5%, just because of the nature of how the human toenail is. We've had toenails since we were cave people. We don't really need toenails anymore. This is one of those things that's kind of left over. So sometimes even with the best treatment, they still grow back. And so we do our best to try to not have that happen, but it has happened. And so when it does, we just address it and do another procedure. Okay, so now we're going to talk about arthritis. And we'll kind of get through some of the informational stuff with arthritis. I think it's important to understand that we all will have some sort of arthritis in our lifetime. Unless you lived on a couch your whole life, you're likely to have arthritis somewhere. There's a lot of different types of arthritis, and as you can see, a lot of people have it. Even kids can get arthritic changes, and I do see some of that, in my more active children now, especially with sort of travel sports and those kind of things. Kids are having injuries at 10 that they used to have when they were 18. It's a leading cause of disability per year, more common in women than men. And then if you look at the bottom where it talks about comorbidities, diabetes, heart disease, and obesity. These are all things that if you really think about it, make sense. These are, and not necessarily everyone, but bigger people, less active people, heavier people, these can cause more problems on our joints, and not just the foot and ankle joints, but every joint, the knee, the hip, the shoulder, even the fingers. Arthritis of the foot and the ankle, that's me. That's my job every day. It can be caused by inflammation. It causes swelling and basically degenerative change of the cartilage in the joints. What it'll do is it increases the joint fluid. That's our body's natural reaction to try to lubricate something that's breaking down, and that's where you get the swelling. It's a frequent component in lots of different diseases. Again, we go back to what we talked about earlier in the presentation about the foot having so many different joints and things that work together. So you can have arthritis in lots of different areas in your foot. I do see it in a couple different places more commonly, but I've seen arthritis in pretty much every joint in the foot. It is a disease of active people. I always say it's sort of like a badge of courage. If you come in and you have, ankle arthritis or toe arthritis or whatever, and again, with this population in the area that we practice in, I have a lot of military veterans. I have a lot of, people that have been on their feet and really ground pounding for a long time. And I do see significant arthritic changes. So here's a couple pictures of the difference between a good ankle, which is on the left, and a bad ankle on the right. You can just see that the good ankle has space and it looks, like you can identify things. Whereas on the right, those two joints, there's no joint left. The cartilage is completely gone and starting to deform itself. And those are actually what rheumatoid arthritis ankles look like. And so we do see a lot of that in this area. We have a really great rheumatologist, Dr. Schoenwetter, that we work with, and she's very helpful with our rheumatoid patients. So the most common form of arthritis that I see is osteoarthritis. So it's just a degenerative joint disease. I call it the wear and tear arthritis. It just means you've been active your whole life, and now you're paying the price. So it's generally a gradual onset. You get some pain at night. You can get pain all the time, but usually it's at night after a full day on your feet. And obviously, the heavier you are, the more sort of pain you can have in the ankle joint with pressure. So rheumatoid arthritis, I do see my fair share of rheumatoid arthritis. It's really what I would consider the most serious form of arthritis because it can affect multiple joints in the foot and the ankle, not only the foot and the ankle, but the hand, the wrist, the elbows, the knees, the hips, the shoulders, pretty much any joint that moves. RA is one of those diseases. It's an autoimmune disease where your body sort of attacks itself. We have these immunoglobulins that sort of attack the other immunoglobulins, and it makes for this sort of degenerative breakdown of your foot or of the joints. So women have this more than men, and this can cause some significant deformity in the foot and the ankle, and I have pretty good treatment options for that, depending. And again, I work with Dr. Schoenwetter with those patients to try to give them the best treatment option, whether or not it be conservative treatment or therapy or whatever, or surgery. So, treatment of your arthritis in your foot and the ankle, and it's like the same as everything. We sort of physical therapy and exercise, depending on your activity level. We can also use anti-inflammatory or other medications, depending on how bad it is. We try to control everything with an orthotic or a special shoe or a brace, depending on how bad it is. And then, of course, as a surgeon, we use surgery as a last resort, but a lot of times people come in and they're here for surgery, and I know it and they know it. And we all sort of come to the agreement like, okay, I can help you because you've already kind of passed through the gates where you've tried everything else. So again, sort of what a normal ankle looks like, cadaver ankle, this is the one on the left, and then a abnormal ankle on the right, where they've actually flexed the ankle and you're looking down at the cartilage, at what used to be cartilage actually, in that area. So that's what a bad ankle looks like. This is what I look at when I do the ankle replacements. So here's just a quick, this talk isn't really focused on the ankle replacement, but this is what our ankle replacement looks like. Looks like it's a 3-component, stainless steel, poly-coated device, allows for excellent range of motion, those people that have really sort of broke down ankles. And again, we have a really robust joint replacement program. Myself, Dr. Brooks, Dr. Drew Brooks, and Dr. Rob Peterson are all sort of the joint replacement guys. And we work together with Cindy Giaquinto and Lloyd De Vera, who are our nurse managers and sort of in charge of it there. And we're real proud of that. We have a really good system and a very good reputation in the area as the only real joint replacement program that's set up here. This will be available. I think we're taping this, so this will be available to look at again and you can just copy and paste that to your web browser. So it's a nice video. Tim is a great guy. He lives up in Mendocino County. Just some background on Tim. I think he's pretty much had every joint in his body replaced. He's your prototype, like Mendocino cowboy. Great guy. Came in, completely destroyed ankle. I put an ankle replacement in it. In him, he's doing great. He comes to visit me every once in a while and brings me a bunch of apples from his ranch. All he wanted to do was ride his tractor again, which I think we did, and he's able to do that. He was actually riding a horse the last time he came down and told me. So if you can ride a horse after an ankle replacement, I think you're pretty good. So there you go. Thanks, Kelly. So let's now we're going to kind of wrap this up with some just generic foot health tips for everyone. Don't ignore pain, right? If you have pain, it's not a normal thing. You don't have to, suffer. Come see me. I'm here. There are other doctors that we can refer you to if it's not just your foot. We're all very happy to help. Look at your feet. Okay. Look at them twice a day. Once when you get up in the morning and once before you go to bed at night. Look for changes in color. Look for skin discoloration. Look for cracks or cuts. Anything that doesn't look normal is a reason to be concerned. And any sort of growth on your foot is not normal. Wash your feet regularly. I know that seems like a very simple sort of recommendation, but get in between your toes. Get in there with your finger and clean it out with some soap, and then dry in there with a towel. It's always nice to keep that nice, clean and dry to prevent fungus from occurring there. So. Trim your toenails with the shape of your foot, the shape of your toe. Again, don't cut them straight across. That's going to create these sharp edges. You kind of cut them sort of in a semicircle. People who are diabetic, poor circulation, they probably shouldn't do that on their own. And I do see a lot of patients in my office for diabetic evaluation and nail care, and I'm happy to help with that. My job can make life really simple if I can do something very easy. Make sure that you're wearing properly fitting shoes. Okay, shoes that are too tight can cause breakdown of your skin and wounds, and shoes that are too big can cause the same problem. You want to get measured. Go to a shoe store that will measure you and put you on the Brannick device, which is that metal cross-looking thing that everybody's seen somewhere in their lifetime. And they'll make sure you get the right length of shoe and the right width of shoe. Wear the right shoe for the right activity. We kind of drove that one into the ground. Just, if you're going to run, you're not going to wear flip-flops. Alternate your shoes. If you can, don't wear the same shoes every day. Sometimes that's harder financially, but if you have two pairs of tennis shoes and you're in tennis shoes all the time, go from one to the other. Don't go barefoot unless you have to. We don't live near the beach, so there's no real reason for you to be barefoot all the time. You can wear some sort of shoe, whether it's outside or inside, depending on if you wear shoes in your house. But, we don't wear shoes in my house, but we have little house slipper sandal things that my wife makes us wear. Be cautious of the home remedy stuff that we talked about. You don't want to do something that's going to damage your tissue just because you're worried that you can take care of it on your own. If you are a person with diabetes, and I'm sure that all of your primary care physicians will echo this, come see us. Come see me, at least once a year. I do see a lot of my diabetic patients every 2 months, and we're able to sort of nick things in the bud as far as problems. I would much rather do that for you than have it turn into a hospital visit where it's much more serious, and my job is different in the hospital than it is in the clinic. So here are just some informational stuff on the internet. You can go check out our NorthBay joint replacement program. You can check out NorthBay's website in general. It's very good. It's a diverse website full of everything NorthBay for you. American College of Foot and Ankle Surgeons, which I'm a member, and then the American Board of Podiatric Medicine, which I'm also a member. These are just good, resources for you as a patient. If you have any questions, they both have really good and really thorough patient sections on the website. Thank you. This is the boys. These are the guys' first day of school. Last year. Now they're at home and they don't hardly even wear clothes anymore. They just wear t-shirts and underwear to school all day. I think my wife has pretty much come to the conclusion that that's easier. So I hope everybody's doing well, and I will answer some questions now. So Kelly, let's just get rid of the slide so it can just be me answering questions. So a couple questions that we got early on were about neuropathy. So I assume those are neuropathy questions related to diabetic neuropathy or just neuropathy in general. Yes, we have plenty of options for neuropathy. First off, I'll tell you what neuropathy is. Neuropathy is dysfunction or a poorly functioning peripheral nerve. You can get it in your feet. Some people get it in their hands. Other people get it in their abdomen. It can be a result of poor blood supply to the nerves. It can be a result of injury sometimes. Car accidents can cause injury to the nerves in the legs, which cause numbness and tingling. There are multiple different treatment options for neuropathy. There are, pharmacologic treatments, which is medication. We do have many medicines that we use that are effective to treat neuropathy, and there are some procedures that can be done with our pain management doctors where they do spinal, like lumbar blocks. Depending if the neuropathy is caused by an injury, we can do a nerve release depending on where it is and what it is. But yeah, most of the medications that we use are reasonably tolerated by most people. They are, it's pills. So it's just more medicine to add to your list. That's what a lot of people tell me, like, oh, another medicine. But that's how we treat it. And if we can just reduce the symptoms, unfortunately, we can't fix the problem when it's a metabolic neuropathy, whether it's a diabetic neuropathy or something from, people, sometimes liver issues can cause neuropathy too. So that's that. And I saw one more question over here. Let me scroll up. So shoes, like what kind of, I get that question a lot too. What sort of shoes do I recommend? Again, you got to find a comfortable shoe. I wear, I'm a runner. I've been running, I run a lot, especially now that we're in COVID. It's kind of what I use to stay sane in all of this. I wear Hoka. That's Hoka. Those are my favorite running shoes. They're a maximalist shoe, which means it's got a really high, sort of thicker sole to it. Although they're very light, they're not heavy. But really, it's dependent on what's comfortable. If you're going to be standing up at Costco all day, first of all, they should have some sort of ergonomic pad for you to stand on, right? So, second of all, wear a good shoe that's measured to your foot, that has a nice arch, that has it's comfortable, really. And if that can be different for everyone. Some people that's a cowboy boot, some people it's a tennis shoe, some people it's a Croc. I just find your comfort level with that. I don't have a kind of a catch-all. It's just really everyone's different. So, all right. So I'm reading a question here about neuropathy. Foot exercises for neuropathy. Well, there are lots of different exercises. One of the main exercises that we recommend for foot neuropathy when there's weakness is get some marbles, put some marbles on the floor, and then go with your foot over top of those and try to grab them and pick them up with your toes. That will strengthen pretty much all of the intrinsic muscles in your foot. Your foot has 4 layers of muscle in it, and that's more than your abdomen has. So you can strengthen your foot. We just worry that, that's going to, what we don't want you to do is walk around barefoot all the time, because then you're at more risk, especially with neuropathy, of stepping on something sharp. Maybe you don't feel it, then you get, you have a foreign body in your foot, and you get an infection, and then again, you end up seeing me in the hospital, and that's never something that people want to do when I have to come visit them in the hospital. So. What causes, I'm just reading a question, what causes a dark coloration of the nails? Lots of things. I mean, a lot of times it could be a fungus, depending on what it looks like. If it's, just a thickening, a darker color to the nail. It can be a fungus. Sometimes it can be something else. It's really, if you're concerned, you should come in so that we can look at it. There are certain things that are more concerning with discoloration, but I would say 99% of the time it's a fungus. And then can nail polish stain your nails? Sure. If you're wearing nail polish, dark nail polish all the time for your whole life, or for a long period of time, then you can definitely have some staining to your nail. So, all right. So if we don't have any more questions, I'm going to sign off. I want to say thank you to everyone for getting on here during this this interesting time that we're all going through. It's a little weird to be doing this through a video chat. There's one more question. How effective is surgery for the fungus? Well, depends on which surgery we do. I would say it's a matrixectomy, where we do the chemical matrixectomy. That is about 95% effective. I'd say 5% of people have some recurrence. We can completely remove the nail and the actual matrix itself, and that's closer to 100%. No surgery is ever 100%. No surgeon will ever tell you it's going to be 100% guaranteed, because that's not the way surgery works. But chance of recurrence, again, about 5% with the procedures that we do in the clinic, and maybe 1% chance in the surgical procedures. I'm going to get off the internet with you guys, and I appreciate your time. Be safe. Take care of yourselves. Take care of your families. Social distance until they tell us that we have to change things. Wash your hands. We'll all get through this together. We're all sort of in the same boat with how we're supposed to deal with it. So I appreciate your time. And we here at NorthBay really do enjoy taking care of you, and look forward to things getting back to normal. All right, everybody, take care.